Even though I'm the young one in the crowd. I don't look like the young one in the crowd, but I am. It's really terrific when you share patients with Dr. Shah and with Dr. Larson that have that same sort of treatment philosophy where they're thinking about risk stratification the first time they see you, and then you just get passed from office to office. So we're going to talk now about sort of the next step. As Dr. Shah said, many patients don't need to go to this radioactive iodine, but when we're dealing with folks that we think the surgery didn't hardly get it all, that there may be some disease left over, or sometimes we know there's disease left over, one of the most important treatments we have is radioactive iodine. I often tell patients, every other cancer doctor in this hospital would love to say, swallow this, it'll go straight to your cancer. That's, in fact, what radioactive iodine does. I've had the pleasure to work with Dr. Larson. He was our chief of nuclear medicine when we got here. He's still our go-to person when I don't know how to use radioactive iodine, or do I think this is going to work, or how much to give or not to give. Steve has an immense experience treating thyroid cancer and is a valuable part of our team. And we asked him to come give us some thoughts about where we are with radioactive iodine now in 2015. Dr. Larson?
Thanks greatly, Mike. It's a pleasure to be here today to talk about radioactive iodine. So when you come to see the nuclear medicine group, I want to give a little bit of context and also to explain the many forms of radioactive iodine you would hear about, and also to show you some of the equipment that you might be placed under and so forth. This will give you a little feeling of what you're going to face, and maybe give you a little more confidence as you go through it. So obviously, the thyroid and radioactive iodine, we use radioactive iodine to even to visualize sometimes the thyroid itself, because the amazing fact is that the thyroid is extremely efficient at extracting iodine from the blood. It does so that nearly a third of the iodine is taken up in the thyroid once it's administered orally. Thyroids that are hyperactive take up more of the radioactive iodine. And so in goiters and benign disease, we sometimes treat them with radioactive iodine if there's a contraindication, for example, to surgery. And then in cancer of the thyroid, or when you have post-surgical remnants of your thyroid left and it needs to be removed because we're concerned that there might be some local extension of disease, we can take it out with radioactive iodine. And then most or many thyroid metastases can retain some capability of taking up radioactive iodine to selectively treat them. So we give you that dose so that it seeks out your cancer wherever it is in the body and provides curative radiation. You'll hear about different types of radioisotopes of iodine. Iodine is an element of the body. All of these radioisotopes are really iodine. They have the same chemistry. Your body can't tell one isotope from another. It treats it identically from a biochemical point of view, and yet they are distinct. They're distinct in terms of their radioactivity properties. Now, I have always been fascinated by radioactivity. It's a huge form of energy, and how we capture that for medical purposes, I think, is going to be one of the great events that we'll see evolve over the next 10 years or so as we still improve further our use of this powerful, powerful force. So there's I-131 iodide, which is used for therapy because of its special properties of radioactivity decay. There's I-125 iodine, which is not used so much but has been used for ablation. It has little different properties of decay, a much longer half-life, and that was thought to be beneficial at a time, but it's largely been supplanted by I-131. There's I-124 iodine, which has properties that make it ideal for imaging with our PET imaging device, and maybe some of you have heard about the PET machine. I'll talk a little more about that. And then there's I-123 iodine. It also has advantages of radioactive decay because it gives very little radiation dose to the patient elsewhere in the body, but is easily detected with commonly available gamma cameras, which are virtually everywhere in the country. Now, one thing you'll see, and the technician or the nurse will bring you to a SPECT CT machine. Looks big and formidable, But all you do is you lie on this pallet, and then you may have these swing around your body in a gyroscopically controlled circle. Or you may even go through this ring, which is actually a CT scanner. Now, these are modern devices which then create an enhanced image of your body, which is three-dimensional, which greatly improves our chance of detecting your tumor. So this is SPECT-CT, and it's used with I-131 and I-123. So your normal thyroid, as we've said, is like a butterfly in the neck. So you see with radioactive iodine, what happens here, this is with I-123, you get that same picture, but now it's created by the function of the thyroid itself. The biochemistry has concentrated the radioactive element and has actually converted the radioactivity to bind into the thyroid hormone in thyroglobulin. So what you're seeing is the distribution of that in the normal patient. Now, sometimes we can see patients who have hot nodules, and in this case, there's a hot nodule here, which is an overactive part of the gland. We can also make that diagnosis, and that's sometimes used. And in some cases, we see a cold nodule, a region where the gland is attenuated by the fact that there's a cold nodule there. So that has to be done by a combination of palpating the gland and the radioactivity itself. There's key biology that we use to achieve the kind of localization I'm going to talk about. One thing is that thyrogen, the TSH, stimulates the gland normally to take up radioactive iodine. It also stimulates other functions we can exploit, like, for example, the use of sugar by the gland is also increased. And the thyroid cancer is also, being a thyroid cell, even if a outlaw cell, if you will, it also behaves in the same way. So the recombinant TSH is used to stimulate the uptake of these processes, even in the presence of thyroid hormone, which normally suppresses the release of TSH. Once the TSH is given, it stimulates these processes. We use high-dose I-131 therapy very selectively in our patient population, as you've heard. When we need it, we use it for ablation after the thyroid cancer has been removed. That means you ablate the rest of the thyroid that may be present, even a small amount that's present, in order to improve our ability to diagnose thyroid cancer if it were to recur in your body later. Secondly, we treat metastatic disease with high-dose I-131. So this is our practice guidelines, which have been published by Dr. Robbins when he was head of endocrinology here, myself, and Dr. Tuttle, among others. And it gives you a summary. This is a journal you can look at if you wish. But fundamentally, you see that total thyroidectomy is always up front, as Dr. Shah said. So all the patients who come to us have a total thyroidectomy beforehand. But there still may be a little remnant of thyroid, and so we will give TSH to stimulate that. Now, this has been a very effective therapy, and it also has avoided stopping your thyroid hormone for a prolonged period of time, 6 weeks and sometimes longer. And very rarely, when we were doing this 15, 20 years ago, I remember patients who had a terrible time with that process. Joan was one of them. She felt terrible during that time. Not everybody does, but some patients even become literally crazy during that period of time. It's rare, but it does happen if you become too hypothyroid. So we use recombinant TSH now, which has truly been a game changer. And we do a whole body scan in most cases, and also if we're going to treat, we use the same preparation. We'll talk about that in a minute. So radioactive iodine is effective therapy in well-differentiated thyroid cancer, ablation, post-surgery, treatment of metastatic disease. And in fact, if you can't take up thyroid in your I-131 in your thyroid cancer, the prognosis is much worse than if you can. So our paradigm, as you've seen, diagnosis of thyroid cancer, you go to surgery. If the low risk, you might have a lobectomy, might have an isthmusectomy. If you're intermediate and high risk, you're considered for radioactive iodine ablation after your total thyroidectomy. We've talked about risk factors. This is the 2015 guidelines. I just mentioned that the American Thyroid Association has revisited their guidelines. And I'm not going to go into all the detail, but as you go down this list, you go from low to intermediate to high. This is where radioactive iodine becomes important. Now, this is Dr. Tuttle's particular listing of how he makes his decision to recommend radioactive iodine. And once again, you see a big tumor at surgery. If there's a lot of thyroidal extension, you can see if there's any distant metastases at the time of surgery or big lymph node mets. With vascular invasion, any of the tumors, if it's poorly differentiated, and if there's a lot of thyroglobulin elevated post-op. These are things that will drive the experienced endocrinologist and nuclear medicine physician to recommend radioactive iodine ablation. But we don't do it in everybody. And in fact, if the tumors are small, as you've seen, and if there is a benign appearance at the time of surgery without extra thyroidal extension and with very few lymph nodes, we will not treat. Instead, we will watch you closely. Doesn't mean we won't follow you, but we will watch you closely and not use radioactive iodine at that time. So first of all, there are various protocols that will be used for you if you come as a patient to Memorial for treatment. And the protocol will be slightly different depending on the perception of risk as it's seen by your physicians working together again as a team. So in the post-surgical group, day one, you'll get a thyrogen injection, but that's only after you've had these careful tests. You'll also be interviewed by a nuclear medicine physician. The tests will be drawn. We will absolutely review your pregnancy test before you receive any radioactive iodine, but if you feel that you might be pregnant, please bring it up. Thyroglobulin will be done in thyroid function tests. Day two, you'll get an injection, and you'll also get a small amount of that isotope I-123 about 2 hours later, and then you'll get a diagnostic scan the next day. And then you'll get I-131 treatment, and mostly these days you'll get 30 millicuries because there's been some very nice studies which have shown that 30 millicuries is equally effective in this setting. So here's a typical circumstance. You get a diagnostic scan with I-123. There is still some residual there in the neck. You get some radioactive iodine for ablation. You get a post-therapy scan also because sometimes we see that there is unsuspected metastases even in this relatively low-risk group. It's rare, but sometimes we do see that. We often see a little bit of liver uptake, especially if there's residual thyroid, because the thyroid gland and tissue that's present can make thyroid hormone, and this is thyroid hormone that's circulated to the liver and is going where it does a lot of its work, which is in the liver. We use that SPECT machine I showed you, and we take pictures of where the radioactivity is, and we usually superimpose the functional picture on a high-resolution anatomic picture. And here you can see the residual thyroid tissue in the neck, but there's nothing else anywhere in the body that we can see. No evidence of any metastasis. This is residual in the neck. Now, there's a limited dosimetry in a low-risk group where we use I-131. This is usually a little higher risk group, thyrogen injection and blood work. We give 5 millicuries of I-131, and then we take a diagnostic scan of the neck and blood work later. This is such a patient example. Now, if you have a very high risk, Then we will do full dosimetry, and then you'll visit us quite frequently. Also, it's important that you will sit down with the doctor in nuclear medicine, and he will take a history, not only a history about your medical condition, but also your social situation, because the decision to treat you will depend upon the results of a questionnaire, which will be given by you at that time. And that questionnaire will include such things as, do you have children at home? How old are the children? Do you sleep with your partner? Do you have adequate facilities if you needed to sleep alone for a period of time, and so forth? And then we begin the actual dosimetry with a thyrogen injection on day 1 and day 2, and then with radioactive iodine. Now then you will come in, and it may be a little bit boring, but you'll lie down on a table, again, that table I showed you for the SPECT machine, and you will have a whole body sweep of the gamma camera, but you will not feel anything from this, because what's happening is the detectors are detecting the radioactivity that's coming out of your body. You have become a radioactive source, not very much radiation, but enough for these sensitive detectors to make a picture of your body. So you'll come back day 3, day 4, day 5, and day 6, and then you'll have a more detailed scan. But we'll use this information to calculate up how much radiation will be given to you. So it's a form of individualized medicine that allows us to tell how much radiation you're going to get, so we can calculate a dose which is safe for you. It's been a tradition here at Memorial, and now I've retired from nuclear medicine as the chief, although I still work just as long hours in my lab, and I want all of those who are paying my salary to realize this immediately. I also say this in front of my friends because they sometimes tell stories out of school to the physician-in-chief, so I have to be careful there. Anyway, but Benoit, Leeper, and Sonnenberg and Rahl are all gone now. But during the time that they were here, they developed these simple guidelines which we have followed since then about the amount of radiation that the body can tolerate effectively, and this has proven to be a very safe approach which we've used for years. So 200 rads to the blood and 120 millicuries in 48 hours, 80 millicuries in diffuse lung disease. There's no limit on single doses, although we rarely give more than 500 millicuries, at less than 300 millicuries if salivary gland complication is a concern. I say this not that you'll remember these numbers, but that you'll realize that there's a great deal of care and consideration and experience that's gone into selecting the approach we take and the dose that you will get. So here's a patient on the dosimetry imaging. This is the patient's head here. The sweeps with the tracer dose show this a bit of uptake in this region of the body where it shouldn't be. So we say, yes, that's a positive scan. There's uptake in the lungs. And then with the therapy dose, you've gotten the big dose. She got a very big dose, 400 millicuries. We see that indeed she has a lot of disease that is spread to her lungs. So the radioactivity is going there, and it's treating those cells. And it is effectively shutting down those cells with this therapy. She also has a spot here. We take her to the SPECT camera. Here she was coming back. We still see some uptake here. This is a different patient, actually. So we can identify very well from using these SPECT cameras, especially in the post-therapy scan, where the tumor is spread. And by using the high-resolution CT scanner, we can see its location very clearly. In this case, it was to a rib. So then that rib, that one spot there, that focal area can be subjected to further treatment with more localized X-ray, external X-ray beam. Part of our team, of course, is radiation oncologists, and they will do that in order to control the tumor so that when the number of metastases is small in the body, for example, we can control it like that. Here's another example of a hot spot that we saw on our scans, and the use of the CT scan shows, fusing them together shows exactly where it is. It's in the bone, it's in the pelvis, it's extensive in the pelvis. Something like this may be treated with radiation. It may even require surgery, particularly if, because this is impinging on the spinal canal. So it allows us to plan in advanced disease better therapy. So Dr. Bowen, for example, an orthopedic surgeon, may be consulted. Now, one of our most serious problems in advanced patients is that your thyroid cancer can become radioiodine refractory. And in fact, distant metastases are the most frequent cause of death in patients with differentiated thyroid cancer, and the drop in radioactive iodine incorporation that may occur is associated with higher mortality. And so new therapies for this are sorely needed. Here's a patient. She wasn't really symptomatic. This is one of my patients who was fine out in the golf course, felt good, but when she took a swing with a golf club, she felt something go terribly wrong in her hip. She'd broken her hip because the metastases had eroded the bone. We want to avoid that. We want to make a diagnosis earlier of the extent of involvement so that we can avoid that kind of problem. Now, one thing about these isotopes of iodine is that they can be used either as a drug to make a diagnosis, like I-124 and PET, as I'll show you, or like I-131 as a therapy. So the two together are indistinguishable from the body. So we use the I-124 as a tracer to show where the I-131 will go when we give a therapeutic dose. Once again, we use the PET machine. This is what that looks like. The patient lies on this pallet. The patient receives an oral dose, in this case of I-124, and 48 hours later is passed through this ring, and a picture is taken. And in this way, we use the PET imaging to improve the dose estimates that we will get to know where it's going. We make it in our cyclotron here on site, and this is one of the developments we have made, supported by the Department of Energy over 20 years or so. Now this is becoming more and more widespread for reasons you'll see. I'm not going to talk in detail about inducing iodine uptake, but that's an exciting thing. So this was one of our patients with I-124 imaging, just to show you what it looks like. He was 53 years old, felt fine, went in for prostate surgery. On his chest x-ray, had nodules, and then he had a papillary thyroid cancer, which was locally invasive. It wasn't huge, but there was an awful lot of lymph nodes, so he was referred for dosimetry. Those of you who may be close to the screen can see some nodules here, and this is what the radioactive I-124 scan looked like. So here we see that everywhere there is cancer, there is uptake of radioactivity. And all of these spots correspond, in this case, to lymph nodes. There's also some natural uptake in salivary glands. You see at the base of the lung, he had very extensive uptake, and then he had normal uptake here in his thyroid. He also had small deposits in his bones. And one thing we are understanding better is that in the more poorly differentiated aggressive tumors, it's often that we see small deposits in nodes in bones, and we can cure those with radioactive iodine in some cases, such as this. So this patient in 2000 had hugely elevated thyroglobulin, a biomarker of his cancer after surgery. As you saw, Dr. Tuttle would view that as quite alarming to have such levels after surgery. And then he was treated with large doses of radioactive iodine, and now he has, I can say that he's free of disease on his last visit to us. So we use this form of radioactive iodine in order to actually quantitate how much radiation is administered. I won't go into detail as to exactly how we do that, but there's physics involved, but essentially it's possible with these detectors to determine how much of the element is concentrated in the tissue. And from there, we know about the radiation characteristics. We calculate the amount of energy that's going to be put into those tissues so we can compute how much. We found that if a dose of more than 2,000 centigrade or rads, which is a radiation dose unit, is given, that the tumor will respond effectively. So that's what we use now as a threshold. So we use molecular imaging as a way to look at key biomolecules like the Silin-24, and these are molecular-based events which help us understand the malignant state in thyroid cancer. So in summary, you're going to see a lot of people in nuclear medicine. Here are some of them that you'll see. These are friendly faces, and they're going to take good care of you over the time you're with us. There's many different forms of radioactive iodine you'll hear about. Each is chosen for a specific purpose, from therapy to PET imaging. Our problem of radioactive refractory thyroid cancer is now being addressed, we think, and there's early promise in what Dr. Sherman will talk to you about, as well as Dr. Fagan, in some of the new drugs that promise to actually reinduce the ability of thyroid cancer to take up radioactive iodine. And using these tools like PET imaging, we can tell just how effective they are and whether or not it's likely there'll be a response to the treatment with alum-31. So thanks very much for your attention.
Thanks, Steve. He's got the most incredible cameras and pictures on the planet. You should go watch a football game in his office. There's these huge screens on the thing. That's just, I keep inviting myself down, but it really is amazing to see how we've changed in the last 10 or 15 years. Instead of just flying blind, to be able to pick out which patients are most likely to respond, get the right doses, and do the right follow-up.